So, Dhruv, should I start?
Yes, Dr. Jha. Good evening, everyone. Welcome to another episode of Jivo Masterclass. Today we have Dr. Sandeep Jha here with us. He's a liver transplant surgeon at Shelby Sanar Hospital, Delhi. And today he'll be talking about uh, basic of living donor for liver transplant. On to you, Dr. Sandeep.
Yeah, good evening.
So, good afternoon, everyone. Yeah, good evening. So, I'm a liver transplant surgeon practicing in Delhi, and
You're welcome.
we get a lot of we get a lot of patients for liver transplant from across the world, and many from Africa also. So, since there are doctors on this platform, I'm going to give you the basics of liver transplant and also how we do a living donor liver transplant and what are the important things that we have to take care while evaluating a patient of cirrhosis and take. So I will try to cover the important aspects, and as you must understand, it's quite complex, but I will try to highlight the important aspect that's important for you to know uh, when a patient is ready for a transplant. And so let's start. So liver transplant, as you know, is a treatment for end-stage liver disease or cirrhosis. Decompensated cirrhosis requires liver transplant. Now, there are many techniques for liver transplant. The two most common ones are deceased donor liver transplant, where you take out a liver from a brain dead donor and then you transplant the liver into a patient who has decompensated cirrhosis. This is practiced in the developed countries where the organ sharing is very robust and they have a lot of organs available. Whereas in Asia and many parts of Southeast Asia, living donor liver transplant has developed tremendously. Because of lack of deceased donors, we gravitated towards more of living donor liver transplant. And this is what I'm going to discuss. Other techniques are, as I have listed, there are many other techniques for liver transplant, but deceased donor liver transplant, DDLT, and living donor liver transplants are two major techniques that are practiced. So, going from the basics, cirrhotic patients, there are three cases of liver transplant progressed. Newer indications came up, which can also be treated with liver transplant. And the majority of them are acute liver failures, where a normal patient suddenly goes into liver failure due to drug-induced liver injury, or in India, tuberculosis drugs, ATTs are very common, or paracetamol poisoning. In Western countries, paracetamol poisoning is very common, which lands up the patient into acute liver failure. The third category that we transplant very frequently these days is acute and chronic liver failure, which is called ACLF. These are less number of patients, but now ACLF has also become an established indication for a liver transplant. Now, when we talk about cirrhosis, in your practice also, you must have seen this etiology differs in many of these patients. It can be chronic hepatitis B due to hepatitis B virus. It can be chronic hepatitis C due to hepatitis C virus. It can be NASH, which has been recently labeled as metabolic associated liver disease. It happens in patients with uncontrolled diabetes and obesity. The patient lands up into cirrhosis and eventually requiring a liver transplant. So NASH or metabolic liver disease is going to be the most common category of patients who will require transplant in the future. Other known are alcoholic liver disease. Around 10% patients don't have any etiology, so they are categorized as cryptogenic. Then autoimmune hepatitis. In children, the most common cause is biliary atresia. So what is the problem? So this picture I have taken to denote what exactly is the problem in cirrhosis. And you must be aware, on the left-hand side, the liver, which is very smooth and has a good color. And this is what a normal liver looks like. And the picture on the right is a cirrhotic liver. Due to repeated damage in the liver due to alcohol or hepatitis B or hepatitis C, whatever may be the cause, the end stage of liver damage is cirrhosis, and the liver looks like this. The surface is nodular, the liver is shrunken, the blood can't flow through it, and which leads to most of the problems of cirrhosis. So this is what we find when we do a liver transplant. The liver is shrunken and hard. And this is how patients must be presenting to you. They have swollen tummy with ascites formation inside. We keep tapping, we taking out the ascites, try diuretics very frequently. And those are the patients might have jaundice, where jaundice doesn't resolve. Usually the jaundice resolves very quickly, but in a patient whose liver is damaged, the jaundice will not resolve. It will go on for 3 months, 6 months, maybe 1 year. The jaundice will just not settle down. And that is one of the features of cirrhosis. Patient
Hi, doctors. I think there is some network issue with Dr. Sandeep Jha's network. Let me check with him. Can everyone hear me?
Yes, yes, please.
Dr. Jha joined.
Yes, we are hearing you. We are hearing you.
All right.
were you able to?
Hello.
Okay.
Hello.
Veins on
We are
his
hearing
abdomen,
you.
dilated vein. Can you hear me now?
Yes, Dr. Jha.
Yes.
Okay. So this is a typical feature of a patient with cirrhosis. Now, the stages that we divide the patient into, and the most common initially presenting symptoms are ascites, water in the tummy, and bleeding. These are the most common presenting symptoms of any patient with cirrhosis. And we divide when the patient has compensated cirrhosis, he has only varices, no ascites. But when he develops ascites with or without varices, it is called as stage 3. And when there's upper GI bleeding along with water in the tummy, it is stage 4. And you can see when you have a look at the probability of death per year. So when the patient in stage 3 or stage 4 cirrhosis, you can see that at 1 year, only 20% of the 20% of the patient will die within 1 year if they are developing ascites with or without varices. If they have upper GI bleeding along with ascites or water formation in the tummy, then 57% of the patient will succumb within 1 year to the disease. And so this is what drives transplant. When the patient is in the stage of bleeding and ascites formation, we have to increase our suspicion that patient might be a candidate for liver transplant, and long-term survival is only possible with a liver transplant when the patients have upper GI bleeding and formation of ascites. Now, how do we evaluate these patients? There's one aspect when we look at symptoms to decide that patient requires liver transplant. Other than that, there are two scoring systems that have been developed that determine if the patient requires a liver transplant or not, or it is severe enough to require liver transplant. So the CTP score, Child Turgot Puck's classification, it takes parameters like albumin levels, bilirubin levels, prothrombin time or INR. It also looks for ascites and encephalopathy. These things are taken into account: bilirubin, albumin, INR, ascites, and encephalopathy. And on the basis of these, there's a scoring system developed, and it is given a score of up to 15. So if the patient, like you can see in this child C, if the patient is 10 to 15 points on this table, then he definitely requires a liver transplant. He's definitely a candidate for liver transplant. If he's in class B, 7 to 9, then we have to take it on a case-to-case basis. If the patient is at 9, score 9, child B, then again, he requires liver transplant. But if he's on score 8, then we see other symptoms and how severe it is, and then decide if the patient requires transplant. Less than 8 score, these patients can wait. They are early cirrhosis, they can wait for transplant or for some decompensation to occur, and then they should go for a liver transplant. Now, there's another scoring system, MELD scoring system, that has become more popular because in the developed countries, this system is used to determine when the patient is listed for a deceased organ. So if the patient has a MELD score of 15, they are listed on the organ sharing network, and then they will get a liver transplant. So 15 score is a surrogate marker that the patient requires liver transplant. And this MELD score considers the creatinine level, the bilirubin level, and the INR levels. And this is a formula. It is a complicated formula, but both these scoring systems are very easily available online. You can get the reports of the patient, you can go online, you can enter the reports, and you will have a MELD scoring system along with the prognosis of the patient. So these are very easily available online. Now, so two scoring system and symptoms. So when you are a clinician and you have to decide if the patient requires transplant, if the patient is having clear-cut symptoms of ascites, upper GI bleeding, encephalopathy, or his kidneys are getting damaged, then definitely patient requires transplant. If they are not meeting the criteria, but MELD score is more than 15 and child's CTP score is more than 8, then the patient has to be referred. Now, I have listed the indications for liver transplant. Now, all of them are not very common, but yes, refractory ascites, when you are having to take out water again and again from the tummy, that is called as refractory ascites, and your diuretics are failing. Your diuretics are not working, so the patient requires transplant. When the patient is having upper GI bleeding or hematemesis more than one time, then the patient requires transplant. If the patient has gone into encephalopathy because of liver, he requires transplant. Similarly, hepatorenal syndrome, hepatopulmonary syndrome. I'll not go into the details of these because you can read them up, but they are what is used. These are the indications when the patient has to be referred for a liver transplant. Other than that, acute liver failure, acute and chronic liver failure, that I also addressed before. In children, biliary atresia, primary sclerosing cholangitis, autoimmune hepatitis, and metabolic liver disease, NASH, NAFLD, metabolic alcohol, all these become indications for liver transplant. There are few contraindications. Now, when you're referring a patient, if you have thought that this patient meets the criteria for transplant, then you have to see certain contraindications that these patients benefit from a liver transplant. They may be a candidate, but they are so advanced or so far out that they will not benefit from a liver transplant. So if they have a severe cardiac or pulmonary disease, even if we do a liver transplant, and cardiac or pulmonary disease will definitely kill the patient. If the patient is taking alcohol and the patient is not ready to quit, if he doesn't have the insight that he has to quit alcohol, then there's no point transplanting these patients, because they will do the transplant and they'll go back to alcohol. So our whole effort is wasted in doing a transplant in such patients. Then liver cancer is also a major indication for liver has gone beyond the liver, or if the alpha fetoprotein level is very high, then there's no use of transplanting those patients, because the recurrence or the liver cancer transplants patients. Uncontrolled sepsis, if patient is having any kind of infection, then it is a contraindication. However, it is a relative contraindication. If we can control the infection, if we can give good antibiotics, antifungal, antiviral, we can control the infection, then definitely the patient can be taken for liver transplant. Then there are certain anatomical problems that can preclude liver transplant. If the patient has cholangiocarcinoma, intrahepatic cholangiocarcinoma, that also is a contraindication. Not much benefit is seen in intrahepatic cholangiocarcinoma. However, perihilar cholangiocarcinoma is increasingly becoming amenable to transplant, and we are doing more and more transplants for perihilar cholangiocarcinoma. And obviously, if the patient has a cancer elsewhere in the body, a CNS tumor or a lung tumor or a breast tumor or breast cancer, then definitely there's no use of doing a liver transplant in such patients. So this slide is very important. What are the indications? How you select the patient that these patients will benefit from a transplant? And then again, in that pool, you also have to see that they don't have any contraindications for liver transplant. So this is a very important slide. Then LDLT outcomes, um, they are very good these days. LDLT outcomes, the survival is 1 year survival is 90 to 95% survival, and recent data says the 5 year survival is close to 70 to 80%. So that means if you transplant 100 patients of today with living donor liver transplant, around 70 to 80% will live 5 years and longer. So this is one of the best outcomes, because when you consider when the patient has cirrhosis, decompensated cirrhosis, they only have a lifespan of 1 year to 2 years if they have a decompensated cirrhosis. But if you do a living donor liver transplant, more than 70% can survive more than 5 years and even longer. So recently in India, a child who was transplanted at 2 years of age went on to at 25 years of age, he has gone on to become a doctor, which was very much publicized in the media. And this is what the benefits of living donor liver transplant are. And if you look at the donors, they all return to normal activity. And donors, there's a slight chance of mortality, that is 0.5% risk to life. Every donor has to understand that. But we do a lot of tests to guard. We'll talk about that later. But all donors do return to normal activity by 6 months. It is said in studies, but practically within 1 month, they are all back to their jobs, and they can do all the routine jobs, not heavy weightlifting, etc., but all the routine jobs, office work, homework, they can do even after 1 month of the donor surgery. So how do we evaluate a donor for living donor liver transplant? This is the most important aspect of living donor liver transplant, because if the donors have problems, then they will refuse to donate their livers. And this happened in United States in 1984, when a few donors died, and then suddenly there was the living donor liver transplant program had shut down in US. Now, due to organ shortage, they are coming up again with living donor liver transplant. But this is a very big problem that we have to guard against, that no donor should have problems after liver donation. And so very strict protocols are made how we evaluate a living donor for a liver transplant. And at any step, if you find any problem, we just reject the donor. If even we find any suspicion that the donor might have problems after the donor surgery, then we refuse to take that donor for a liver donation surgery. So, what a potential donor is 18 to 55 years, obviously known medical disorders. They should be lean and thin. They should be able to give consent. They should understand the process of living donor liver transplant and be ready to give a informed consent. And they should be able to comply with long-term follow-up. According to Indian law, they should be related to the recipient. In many countries, altruistic donor should be related to the recipient. Only then we will get the ethical or legal clearance to go ahead with the liver transplant. And all these donors are evaluated by multidisciplinary team that involves a liver transplant surgeon, a hepatologist, a gastroenterologist, anesthesia person, a cardiologist, a pulmonologist, and in cases of females, a gynecologist is also involved to evaluate these donors. So before we begin the donor evaluation, we have a discussion with the donor that he understands all these aspects of liver donation. He also understands that he's doing a good deed, but he stands a 0.5% risk to life when he goes for a liver donation. And long-term expectations, and also that every donor has his gallbladder removed, because gallbladder attached to the base of the liver, and when we cut the liver in two halves, the gallbladder is useless after that and might cause problems. So we remove the gallbladder along while doing the donor hepatectomy surgery. This is the complete flow chart, how we go about the evaluation. So there are three components: medical evaluation, there's an ethical evaluation, and there's a documentation process. And then all this is approved by an authorization committee, which is headed by the government officials, and they give authorization for the transplant. Only then the surgical team can proceed with a liver transplant. At any step, if there's a problem, then we cannot proceed with the liver donation surgery. This is when we have a recipient of A group or O group donor can donate to the recipient. We have to be sure that plus or minus the RH status of the donor does not matter. It is only the ABO blood group that matters. An A recipient can receive from A or O blood group donor. B can receive from B or O blood group donor. A recipient of O blood group can only receive from an O blood group donor, and AB recipient can receive a liver from AB, any of the blood groups, basically. So the most important aspect of surgical planning in a living donor is a contrast enhanced CT scan that is done in triple phase. That is, there are three phases in which the patient is run through the CT scan machine, and the evaluation is in the arterial phase. It is done in a portal phase when the blood is when the contrast is flowing through the portal vein, and then a delayed venous phase when the contrast is flowing through the hepatic veins. And that's how we determine the anatomy of the liver, and that is how we proceed with the transplant. So I'll just discuss the basic aspects of how we plan this surgery. Now a CT scan gives us these images. These are the planning images that we get from a specialist CCT triple phase scan of the donor. And you can see the portal vein anatomy is well delineated. The hepatic veins anatomy is shown in this picture. The arterial anatomy is shown in this picture. And that is how we determine if this donor is fit to undergo the surgery, because the portal vein has to be divided here. And if the stump is short, then we cannot take the donor for donor surgery. This is how we evaluate for the fatty liver. Some donors have fatty livers, and it is evaluated on a non-contrast CT scan, and a liver attenuation index is calculated. And if that liver attenuation index is anywhere less than 0, then the donor is declared unfit, and we don't take the donors for liver donor surgery. So this is a protocol that we follow for donor steatosis. Like I said, liver attenuation index on a non-contrast CT scan is required to see if the liver is fatty or not. Increasingly these days, MR or MRI is also being used to evaluate for fatty liver, but it differs from center to center. We use a CT scan to see if the liver is fatty or not. In doubtful cases, we can go with an MRI scan or even with a liver biopsy. If the donor is requires a liver transplant and we have doubts about the quality of the liver, then we have to do a liver biopsy. Because you have to understand that the whole surgery is dependent on the quality of the liver. So we take out around 60 to 70% of the liver from a donor. That is the right lobe. The right lobe in an adult we take out from the donor, and we remove the bad liver of the recipient. The cirrhotic liver is removed, and we put in the around 60 to 70% of the donor liver into the recipient. And then we make the connections, the hepatic veins, the artery, the portal vein, and then the liver functions. So if the quality of the donor liver is not good, the donor will also have problems and the recipient will also have problems. So it is with utmost intensity that we evaluate the quality of the donor liver, and if we have any doubts, we just reject the donor. So to confirm the quality of the liver, we have to do a liver biopsy sometimes. Not in all cases, but in a few cases we have to do a liver biopsy to ascertain the quality of the donor liver. Now, like I was saying, we take around 50 to 60, 60 to 70% of the liver. This is where the Cantley's line is. The gallbladder is here below, and the IVC, the right hepatic vein, and the junction of right hepatic vein and the IVC is here. So we mark a line like this and we cut along this line, and this is called the Cantley's line. So the segment 5, segment 6, segment 7, and segment 8 are the part of the right lobe, which is taken out and given to the recipient. In this picture, we are not able to see the segment 6 and segment 7 because it is lying posteriorly. When we see the liver from the front, we cannot see the segment 6 and segment 7 because they are lying posteriorly. When we look from the front, we can only see segment 5 and segment 8. And this 5, 6, 7, 8 forms around 60 to 70% of the total volume of the liver, because the left lobe is usually very small in these patients. The left lobe is small in all the individuals. Actually, the right lobe is much bigger. So in adults, we take a right lobe. In children, we take left lobe. This is another picture showing the anatomy where we have to divide the right portal vein, we have to divide the right hepatic artery, we have to divide the right bile duct, and that's how we retrieve the graft. That's how we retrieve the graft from the donor, by dividing here in the portal vein and the hepatic artery. This is a picture that I was trying to say, that the segment 6 and segment 7 go behind the liver, and if when you look from the front, it is not visible. And this is where we divide the liver along the middle hepatic vein. The liver is divided, and so these 4 segments from the right lobe, and this is the left lobe. And this is the intraoperative picture, what I was describing you, the Cantley's line. This here is the falciform ligament, and this here is the falciform ligament which has been divided. This is the left lobe. This is the segment 4. And this is the right lobe of the liver. And this is what we have marked. This is the line of transaction, ischemia line that we mark. And then we divide the liver along this line and then take out the right lobe of the liver. So these are a few intraoperative, how we loop the portal vein, the right hepatic artery, the common hepatic duct, and how we divide these structures during the surgery. And there's a lot of anatomical variation in the arterial supply, the biliary anatomy, and like this is the biliary the MRCP that we do to see the biliary anatomy, and on basis of which we decide if the donor is fit or not. So this is how we put the graft into the recipient. These are the connections we make. You can see here the right hepatic vein has been attached to the IVC here. The portal vein has been attached to the portal vein of the recipient, and the right hepatic artery is attached to the common hepatic artery of the recipient. And here the green color bile ducts are divided to the root loop of the intestine, and they can drain into it. This is the further images of planning how we divide along these lines. This is where the liver is divided. This is the MHV, middle hepatic vein, and this is along where we divide the liver when we are cutting it. And this is another diagram representing how we divide, how we split the liver and we divide along the right hepatic vein. This is the right hepatic vein, and we go on cutting the liver through this, and then we take the right lobe and implant. This is another picture showing what we do. As you can see, this transaction line goes along the middle hepatic vein, the right hepatic vein, and the whole of the liver is taken out and put into the recipient. Now, like I said, the right lobe and left lobe, if the recipient is adult, if he's an adult individual, then we take the right lobe because adults require more mass of liver. So in adults, usually we go with right lobe of liver. If it's a small child who requires less volume of liver tissue, then we go for a left lateral segment or maybe a left lobe of the liver is transplanted in these children. So graft recipient weight ratio is a ratio how we decide how much liver volume is adequate. If the liver volume is less than the GRWR, then it is doubtful to do the transplant. Ideally, 0.8. The graft recipient weight ratio on the donor, 30% of the liver the donor is fit to be taken for a liver transplant, and then CCT, triple phase evaluation, along with liver volumetry. This is what gives us all this information of proceeding with a living donor liver transplant. Now, these are a few of the operative pictures that we do while doing the anastomosis. This is the portal vein that we are attaching here. This is the hepatic vein that we are attaching here. This is the bile ducts. And at the end of the transplant, we'll do a Doppler. We do a Doppler of the liver to see if the hepatic artery, the hepatic veins, the portal vein are functioning properly. And only then we complete the transplant. So these are the intraoperative phase. First, we remove the liver from the recipient. Then we take the liver from the donor. And then we do some benching on the bench where we make the graft adequate to be transplanted. And then we implant and then we reperfuse. There are many issues in the post-operative intensive care management that we have to take care, right from hemodynamics, how much fluid we have to give, liver allograft issues, there are respiratory issues, cardiovascular issues. So a very good critical liver. Any of our recipients have all these lines when they are in the OT and when they come out to the ICU after the transplant. They will have an endotracheal tube, they will have an arterial line, they will have a central venous line or a wedge pressure or a ECG, SPOB. They have temperature probe, nasogastric tube, Foley's catheter, and maybe 2 or 3 abdominal drains when they come out of the OT. Every day we monitor these patients. We keep the recipients at least around 18 days in the hospital, and every day these tests are done to make sure that the liver graft is functioning properly and there are no problems with the liver graft. There are many issues that can come up after the transplant, but we can't go into most of these issues. But most important is the risk of infection and rejection. These are the most common problems that can happen after a living donor liver transplant that we have to guard against. But I will not go into the details because it is a very extensive topic. Common complication leak and bile obstruction, especially in living donor liver transplant. You can see 10 to 26% of the patients can have these complications. Then there's portal hepatic artery thrombosis and portal vein thrombosis that can happen. Now, their immunosuppressions are given in these patients to maintain, because when we do a living donor transplant, the body itself will reject the liver, and these patients require immunosuppression to make the graft survive. And all these most commonly used, tacrolimus is used these days, mycophenolate is used this, and steroids. There are three drug regimen that is used for immunosuppression. That is tacrolimus, mycophenolate, and corticosteroids are most commonly used, and they all have their side effects, which have to be managed during the transplant and even after liver transplant when they go back to their home countries, because tacrolimus and might go on for 6 months, 1 year, or tacrolimus can go on. These complications have to be managed early, and if some other complication arise, then we have to manage those complications also early. So this is a chart showing a few problems have recurrence because we do the transplant for cirrhosis, but hepatitis B can come back. Hepatitis C virus can again damage the liver if the patient has not been treated for hepatitis C. Cancers can come back, primary biliary cirrhosis can come back, autoimmune hepatitis can come back. Patient can go back to alcohol and damage his new liver. So we have seen all of these things happening after a liver transplant, and that's why it's very important that the patients go back and follow up with a doctor who understands all these issues and can deal with these issues. Only then these patients will get the complete benefit of a liver transplant. And that's a very that's where cooperation, collaboration be important, especially when we are talking about liver transplant recipients. Now, this is just the pictures of our donors. There's a donor on the left side. She's a very successful model now. So, a picture can say 1,000 words, and this is what by one picture I can show you that donors don't have any limitations. The lady on the left side is a model who's a successful model, and the guy on the right side, this is him immediately after a liver donor surgery, and this is him after 1 year after a liver donor surgery. And you can see the transformation, and this picture should assure you that there's no limitation after that was the purpose of this picture. And I'll finish with a very interesting case that we did. Of age, and he had liver cirrhosis due to biliary atresia, and how we took the liver, and this is the left lobe of the liver that you can see in the hands, and then we divided the liver. We actually cut and discard a part of the left lobe of the liver because the recipient was too small and the liver could not fit into his body, because it was an adult. The mother was and her liver could not fit into his body. So we had to cut down the size, and this is how we divided the liver into small inside the child. And this is how it was looking when it was fitted inside the child. In this picture also you can see the liver is looking so big for his small tummy of the child. And this was the child after the transplant, immediately after. This was before the transplant, and this is after the transplant. That patient was in the ICU when he was shifted to the ICU, and this is about a month after the liver transplant when the patient went back to his home country. So to conclude, liver transplant is only curative therapy for end-stage liver disease. There's no other medication, nothing you can do when the patient has developed decompensated cirrhosis. And the earlier you refer the patient for a liver transplant, the better the outcomes of liver transplant are. And if the patient carries on with cirrhosis, he'll become weak, he will develop infection, and unfortunately, the outcome of liver transplant surgery also be affected. So you should identify decompensated cirrhosis early and refer the patient for a liver transplant early if you want the patient to completely benefit from the transplant. Overall success rate is 90 to 95%. It requires meticulous planning, good knowledge of anatomy is mandatory, and post-operative management is also very challenging, and long-term follow-up and compliance, which is actually lacking in patients who come from other countries, because we try to follow up those patients, but we are unable to follow up those patients, both with regards to immunosuppression, the complications, recurrence of disease. We are, unfortunately, our hands are tied when you want to follow up these patients. And that's where the role of doctors in the home country is very important, in collaboration with liver transplant teams in India. So with that, I would conclude and say thank you for your patient listening.
Thank you, Dr. Jha, for your presentation. I think we have one question in chat, which I think you have already addressed partially. Dr. H2, if you want to ask your question, that would be great if you want to unmute and ask. Dr. H2, are you on call? Hi, Dr. H2. Okay, so let me read the question. She's thanking Dr. Jha for the update. She's talking about one patient from Ethiopia who underwent liver transplant in India a couple of years ago. But the transplant was successful, but the patient developed serious infection and was admitted to ICU. Infection control was very difficult there in Ethiopia, and finally the patient died. So what are the post-op infection? Like, why is post-op infections difficult to control, and how can this be solved? Hello.
So my advice, my point would be that yes, can you hear me?
Yes, Dr. Jha, I can hear you.
Can you hear
Yes,
me?
Dr. Jha.
Yeah. So my advice would be that post-transplant patients are immunosuppressed, and they catch infections easily, and even minor infections can escalate very quickly. So what we usually do is hit them early and hit them hard is what we follow. So if the patient is transplant recipient and you are suspecting infection, then immediately we should get all the blood investigations right from culture, procal, everything done. Look for a source of infection as quickly as possible and empirically start very high grade antibiotics in these patients. So this is what my advice would be. Obviously, with better collaboration between doctors in Ethiopia and India, I think a better job could have been done. But yes, infections in post-transplant patient is reality, and they catch infections easily, and they also escalate very quickly. So we have to be quick to act and hit them hard with very high antibiotics. Uh, and mostly they are very different from what antibiotic protocols for normal patients are. I would say we would go one step or even two steps ahead of the antibiotic requirement for a normal population in these patients.
Got it. I hope it answers your question, Dr. S2.
Yes, yes. Thank you very much, Dr. Jha. Yeah, that was a couple of years ago. The patient was end stage liver failure liver patient, and she was around 50 years old, and she went to India. Transplant was done, And immediately after few days, she developed serious infections there, admitted repeatedly to ICU in Indian hospitals, and they were able to control it. But immediately after a couple of days, then she has some uh, serious infections again. Uh, is there anything like uh, bacterial or fungal infections which could not be controlled due to the liver transplant, probably due to protein deficiency or something that the bacteria are flourishing? And finally, she came to Ethiopia. We followed her, and after few weeks, she developed again. She was isolated. Actually, she was isolated. She was living alone. Infection preventions were applied, but suddenly she developed another serious infection. She was admitted to our hospital in ICU, but she couldn't make it. The reason I want to ask is liver transplant, like any other transplant, they are at risk of infections. But why is it difficult to control the infection? Why is the recurrence? Is there anything to do with the medication she's taking, or is there any new liver? The new liver being to her immunity, I'm really worried.
Dr. Eshtu, it's the immunity, because we are suppressing the immunity of the patient. We want the liver to survive, the new liver. If we don't suppress the immunity, the patient's own immunity will damage the liver. So we have to suppress the immunity. But the fallout of that is the patient is exposed to very severe infection. And it doesn't happen in every patient, but it can happen in a few patients. And we have to hit them early, and we have to hit them hard with the maximum antibiotics that you have. And definitely in this case, we get cultures done very regularly. First, we have to eliminate any source of infection. And unfortunately, there's a whole lot of management that goes that I can't discuss here. It will be very complicated. And especially on hindsight, when a patient has not done well, it's very difficult to comment what happened and why it happened. But yes, broadly, these patients are immunosuppressed. They will have infection, and their infection will spread very fast. So you catch them early, you hit them hard, and you give them the complete course of antibiotics for 14 days at least, and very high grade antibiotics.
Thank you, Dr. Jia.
Okay, thank you.
Uh, Dr. Sunday Olik, if you want to ask a question.
No, my question is only what's the cost effectiveness for this surgery?
It's extremely cost effective. A few $100 can buy you 40-50 years of life. If the patient is dying of cirrhosis, getting a liver transplant can give you a new life. How much value would you put on that?
And possibly what's are the side effects of the surgery and the post-operative complications?
So most of the complication and side effects happen in the first few months of the transplant, mostly in the first month of the transplant. But at the end of 1 year, around 80 to 85% patients are doing well. 80 to 85%. And these 80 to 85% patients would not survive if they did not get a transplant. Okay. So that answers your question. What is the effectiveness? So like I showed you in the slide, that at
Yes.
1 year, 57% of the patients will die at the end of 1 year if they have bleeding and ascites. Now,
Okay.
with transplant, more than 80% will survive at the end of 1 year, which is itself a very big benefit. Secondly, not all these patients have only bleeding or ascites. Some have cancer, some have encephalopathy, some have extreme sarcopenia. So all these patients have even poorer survival. And then to get them to live for 15, 20 years is the miracle of liver transplant.
Okay. Thank you for your presentation.
You're welcome.
Dr. Nasoro, do you have any?
Yes.
Hello.
Hello, can
How
you
are
hear me?
you?
Good afternoon.
Good
Fine,
afternoon.
fine.
Good afternoon too.
Okay, thank you so much, Doctor, for the presentation. I'm Dr. Sunday from Nigeria.
Hello,
I
well,
want to know. Okay, I put the question on the chat box, but I just maybe couldn't see it. I want to know the fate of the donor. Knowing fully well that this donor is donating his or her liver. So what will be his fate after donating and maybe possible complications after this donation? Thank you.
okay, good question. Donor is absolutely fine after the liver transplant. Only see, after a complete evaluation, the risk to life is 0.5%, but even that is old data. Currently the donors are very safe. Whenever we feel a problem, we don't take the donor for liver transplant. If you talk about fate or life after liver donation, they are discharged, they are up and about after 2-3 days of surgery. They are walking around, they are eating food. Okay, by day 6, day 7, they are discharged from the hospital. By day 10, they can travel back to their home country. Most of them travel back after 10 days after the donor surgery. They are able to travel back. After about 2-3 weeks from the date of surgery, they can do their office work, light household work. They can work around the house. They can sit in an office and work on a computer and sit on, heavy running around they cannot do, but office work they can do. Only restriction is for 3 months they don't have to lift heavy weight. That is the only restriction that the donors have. After 3 months, they can lift any weight, they can do anything. And that's why I would the picture I showed you, it is very important because I wanted to highlight this picture. Dr. Sunday, this is the picture of the donor that I showed earlier also. So this is the donor after 1 year of donor surgery, and on the left side she's a model and a successful practicing model after the donor surgery. So that's why I showed these pictures, that if you can see the picture, you won't talk about fate of the donor. The donors are absolutely fine and they live a very fulfilling life after the donor surgery also.
Okay. All right.
Okay,
Okay, thank you so much.
Thank
you're
you.
welcome.
Dr. Nasoro, you had some question. You were trying to speak.
Yes. How are you?
We are
I'm
good.
good, doctor.
First of all, I say thank you for this session. It has been nice and it's nice. But for some of the cases that I've seen, whom have underwent what we call liver transplant, most of them usually have at least a half-life of 3, 4, 5. The one who has tried mostly is 5 years. So, of how efficacious will it be if someone had already done the first transplant, and now the livers the same failed? Will you
do the second replant, or how to go about it. And on the other side, you find someone with who needs liver transplant. Apart from their ascites, most of these clients, you find them, they're bedridden, and like their locomotive state, it's not up to the required levels. Kindly, are there any other extra investigations and management that you could offer to this client, so that whatever he or she's experiencing can make her at least resume her normal activities, her normal life, and other? And if so, are there any other foodstuffs that if someone has it maybe in his or her daily meals schedule, which of the some of the medicals and the recommended veggies and fruit also that will help that person too, at least to regain that faster healing and good prognosis from the first or the second transplant? And if so, are there any other foods that we need to prohibit this guy or this lady, so that a recovery is an up?
So, doctor, if I understand correctly, you are talking about the diet in cirrhosis. What
Mhm.
diet can prevent cirrhosis? Unfortunately, there's no diet recommendation that can prevent cirrhosis. The cirrhosis has happened because of hepatitis B virus, hepatitis C virus, alcohol, diabetes, obesity. So these are the causes. If you want to prevent cirrhosis, you have to address these causes. The patient has to stop alcohol, has to be treated for hepatitis B, hepatitis C. His diabetes has to be controlled. His obesity has to be controlled. He has to quit alcohol. So, if you want to prevent cirrhosis, these are the things you'll have to do if you want to prevent cirrhosis. There's no drug, there's no medication that can prevent the development of cirrhosis if the patient chooses to answer your question. No dietary thing can prevent cirrhosis. However, once the patient has cirrhosis, there are definite dietary recommendations, that is high protein diet and low salt intake, that is recommended to prevent the complications of cirrhosis, especially the low taking a high protein diet and taking low salt. Other dietary recommendations are they should be taking more frequent meals and snacking every 3-4 hours, protein snacks. So these are the general recommendations for any patient with cirrhosis. Now, I don't agree with you about the outcomes of liver transplant, because very, very large studies all across the world have shown that 1 year survival is close to 85 to 90%, and 5 year survival is more than 70%. And even now, 20-year survival data is coming. Patients after a liver transplant are surviving as long as 20 years. And the survival rate in that case is around 70%, in that case also up to 20 years. So, Dr. Nasoro, it is the benefit of liver transplant is definitely that long. We are not able to achieve it because of the problems, like the doctor earlier discussed the infection. So we are not able to achieve the same outcomes for our patient because there is no continuity of care. We do the transplant, patient goes back, and then he succumbs to one or the other complications that can happen. Whereas in Western countries, they do the transplant, they follow up with the patient and prevent the complications, and the patient can survive 15, 20 years, even more. And the quality of life is very, very good. The patients who have a successful transplant, they come to us after 3 months. We can't recognize the patient because they change so much. They become stronger. The muscle mass comes back. The tummy goes inside. So benefits of transplant, if you see a patient who has had a successful liver transplant, you will never think of it that way, because when you see the benefit, then you're very overwhelmed by what outcomes a liver transplant can give. However, I understand medical tourism. When the patient comes to India, gets a transplant and goes back, definitely there are a lot of problems, because we are not talking to doctors there, we are talking directly to the patients, and they don't understand, they don't follow up, they don't understand the seriousness of things that are happening. And that's why you are getting the experience that they only survive for 3 or 4 or 5 years. But there are a lot of international data now that liver transplant patients can survive up to 20 years and longer, nearly
Okay.
60-70% of patients.
Okay, Doctor,
And
I get
that is
that
what
point.
we are trying to do here.
Hello, Doctor, are you hearing me?
Yes,
I get
yes.
that point. You see, the same things, they usually happen when you meet someone who has got the liver issues, and also it has kidney failure and others. So remember the drugs you commonly use for someone who has got kidney function uh, and other conditions, it becomes a challenge. Then either of the condition trigger another one, or what relation are they? You remember there is this old lady I described you. She's now 100 years. She had kidney failure. So we have been dealing with supplements. We have been dealing with at least sustaining her glucose levels and others. And now the time, there is not any ascites, but it's generally tender. I had requested from one of our colleagues via WhatsApp, and still I'm trying to follow up. I see if I can get time so that you can do the assessment. I'm trying to meet uh, the relatives to the mother, but my worry is that
Doc-
of what
Dr. Nasoro,
of
I'm
what
sorry.
percentage,
Dr. Nasoro, I'm sorry.
of what percentage? You can't hear me.
No, it's not clear at all. What I would suggest that you can have my number and you can send me the query directly on my WhatsApp. I can reply to you. Okay? We can discuss it on private chat. It's not very clear. I can't understand any.
Dr. Nasoro, you can send it in your work group to Jivo. We'll help you get the answer to your patient.
Okay, so thank you, doctor. But I will be making a call maybe possibly tomorrow by 9, 9
Yeah.
a.m. That is Kenyan time. I don't know on your side. Which time will it be? Is it appropriate? I schedule that call so that maybe we
Yes,
also
yes.
communicate with the relative.
Sure, sure. You can call me. You can drop me a message on WhatsApp.
Okay. And now, since you had mentioned about 3 months stay from the hospital, the patient recovers and it becomes, or he or she becomes strong after the treatment and after the transplant. So this type of stay, first of all, you told me that you facilitate that, but now the payment for the stay, of what possibility should someone just be willing and possibly having so that can get a salary from the other side? Hello, doctor, are you getting me?
Clear.
Yes, and then
I can hear you, but it's not very clear. I didn't understand it. In that.
I asked the previous lady who responded to my call when I called the office number. I asked about if we can. Okay, let me call you by tomorrow. But I guess.
Okay, sure, sure.
No, you're feeling right. So, sorry, kindly I request. Let me just make that call tomorrow so that we can uh,
Yeah, sure.
Dr. Dianal, we have a question from you. If you want, you can unmute and ask.
All right. Can you hear me, please?
Yes, doctor.
All right.
Yes, I
I
can hear
think
you.
early it is mentioned that the metabolic liver is becoming the main cause of liver transplant, especially in the future. So, what the reason behind for the increment of this metabolic liver disease to extent of the cause of liver transplantation is one of my question. And the other, maybe the additional question is there any, because the liver anatomy is the left and the right liver lobe anatomy are very different, even though there are main divisions are there. So is there any difference on the outcome where a patient gets the left lobe and the right lobe, especially in infant? We said the preferred one is the right lobe, yeah? So is there outcome difference when the patients get either of the lobe?
So your first question is regarding metabolic liver diseases, and this is data from Western countries, especially US, where it is increasing because of diabetes and obesity. So they are getting a lot of obesity and also diabetes, which is uncontrolled, along with certain factors like lipid hyperlipidemia and thyroid issues. So this is all a complex metabolic syndrome. So metabolic syndrome is rising. It is the data from US, and we are seeing it in India also, that number of non-alcoholic steatohepatitis, or now it is called as metabolic associated fatty liver disease. So these incidences are rising because of uncontrolled diabetes, obesity, sedentary lifestyle that is very common in Western countries and also happening in India now. So that's where it comes from. And secondly, we have treated hepatitis B, we have treated hepatitis C, we have good drugs for it in India and many other countries. So the incidence of hepatitis B and C is coming down. It is easier to control now. Also because of vaccination, hepatitis B is anyways coming down. So those things have been controlled, and alcohol intake is also on the lower side because of more awareness. So combining these hep B, hep C, and alcohol is coming down, whereas uncontrolled diabetes and obesity is a new problem. So that's where metabolic syndrome or metabolic associated fatty liver disease is rising, and it leads to cirrhosis, and hence the maximum number of liver transplants in 2024 in US was due to non-alcoholic steatohepatitis. So that's why it is rising, and it is happening in India also. So that's for the first part of your question. The second part of your question was, uh, what was your question?
Sorry, the outcome difference. The
Yeah, so
outcome.
there's no, not really. There's no outcome. If the technique is good, there's no difference in outcome. If we transplant a right lobe or a left lobe, it is only because the adult requires more liver mass, so a right lobe is done, and a child requires less. The metabolic demand of the child is less, so we can get away with a smaller liver, a left lateral segment, or a left lobe. There's no difference in the outcome. The only difference is for the donor, in which when we remove the left lobe of the liver, it is smaller, so the recovery is slightly faster, complications are slightly less. Right lobe of liver recovery is little slow because The right lobe forms the bulk of the liver and it has to increase in size. But essentially, there's no difference between a right and left lobe transplantation. Overall difference, there's none.
Thank you very much. Thank you.
All right. Any more questions, doctors? Else we can end this masterclass for today. Anyone, any more questions? All right. Thank you, Dr. Sandeep, for taking out your time and conducting this masterclass today. To everyone else, we'll meet again on next Sunday with a different topic and a different masterclass. Thank you, everyone, for joining.